This is Population Health Weekly. We bring the science to your street. One small habit, one clear choice. Right where real lives meet. Every voice, every choice, every truth that we share. Public health
This is not a sports show, but consider an analogy from cricket and football. Both adopted video reviews to reduce errors. The decision review system, DRS, in cricket, the video assessment referee, VAR, in football. The intention was noble, but the results? Mixed. Lost time, emotional reversals, soaring costs, and persistent judgment errors, even with all those cameras. If technology can't perfect a simple game, what hope or risk does it hold for healthcare? With its infinite complexity, we will return to this question. And if you don't care for sports, that's fine. That's not what this episode is about. It is about you, and about a semi urban family we will call Al Rashids. Layla runs a tailoring business. Her husband, Omar, is a school teacher. Their son, Khalid, is a student. They have smartphones and basic digital literacy. But when healthcare enters the screen, things get complicated. Welcome to Population Health Weekly with me, Shahnur Azhar, and my co host, Erin Rodgers. Today, we begin a brand new series for the month of July. Click, Care, Connect, a global guide to digital health. Erin and I have seen a bit of analog era, but we have clearly seen nearly all aspects of public and private services being automated, including healthcare. This is a work in progress, an interesting topic that concerns all of us.
Hello, Shanor, and hello to all of our listeners. Talking about digitalization, I have lost count of health apps I've tried long ago, many of them still sitting in my phone. But I'm looking forward to our new series this month. And in today's second half of the show, I'm introducing The Dispatch, a monthly opinion from an expert on last month's theme.
Let's walk through five key aspects of healthcare: patients, hospitals, technology manufacturers, insurers, and governments. Each one shapes how this family, Al Rashids, and millions like them navigate the digital shift. Let's begin with the patient scenario. What are they facing? Laila receives an automated text, a reminder: schedule a routine blood test. In the past, she would have called the clinic, spoken to a receptionist who knew her voice, fixed a time. Simple. Now, she is directed to a mobile app. It asks for login credentials she cannot remember. It uses medical terms she only half understands, and offers no option to speak to a human if something goes wrong. This is not isolated. Studies are starting to capture this transition. While many patients experience initial anxiety when automated systems replace direct human conversations, that anxiety often subsides over time. Satisfaction tends to increase, particularly when patients receive adequate training and ongoing support during the transition. The technology itself is rarely the problem. Facing it alone, without a guide, is. For Layla, the automated appointment system was precisely that kind of struggle, a source of confusion and frustration in its early interactions, leaving her longing for the voice of a receptionist who knew her name. Now, consider hospitals. Treatments and diagnostic procedures are being modernized at breakneck speed. AI scanners read x rays with remarkable accuracy. Robots deliver medications to wards. Electronic dashboards track bed availability in real time. But let us return to our sports analogy, just for a moment. In cricket and football, video reviews did correct some clear errors. But costs exploded. Smaller clubs and less wealthy cricket boards simply could not afford the infrastructure, and the game slowed, frustrating players and spectators alike. In healthcare, the same question presses upon us. Are we genuinely improving quality of care and expanding access? Or are we simply piling expensive gadgets onto already strained systems? Consider Umar, Layla's husband. He often accompanies his aging parents to the local hospital. The new digital check in kiosks look impressive until they crash, which they occasionally do. There is no backup plan. The staff are overstretched. Troubleshooting is a work in progress. The technology was designed for ideal conditions, not for a busy semi urban hospital with one IT assistant and intermittent power supply. We are not here to condemn progress. We are here to ask a different question. Why not run pilots before rollouts? Why not think of patients as partners? That brings us to technology providers, the companies that build these tools. Estimates put the global digital health market valued around 220 billion US dollars in 2023, projected to nearly double by 2028. This is a vast industry. Smartwatches, AI diagnostic software, remote monitors, telemedicine platforms. But these products rely on complicated supply chains, microchips from one continent, assembly on another, software written in a third. When a device breaks in a smaller hospital, finding a replacement part or a technician can take months. Manufacturers would want to sell their products, and with marketing teams out there, almost always find a good buyer. But a high tech computer can become expensive e waste within a year if no one can maintain it. The question for manufacturer is not merely can we build it, but can we sustain it everywhere for everyone? Now let's turn to the fourth key aspect of healthcare: insurers, the financial gatekeepers. In the pre digital era, claims were processed with stacks of paper forms, rubber stamps, and weeks of waiting. Now, algorithms approve or deny claims in milliseconds, faster, but also colder. Recall Umar of Al Rashid's, who now sits at his dining table, scrolling through renewal options on his phone, comparing family coverage plans for his wife Laila, son Khalid, and himself. One plan offers a lower premium but restricts coverage to telemedicine only. For Umar, with his reliable smartphone, that might seem appealing. But he remembers his cousin, who lives in a nearby rural district, complaining of signal that drops constantly irrespective of the provider. Video calls? Impossible. Another insurance plan offers broader coverage, but charges extra for any digital consultation. Omar is not a tech expert. He simply wants to know that his family will be covered, without hidden digital pitfalls. Insurers are adapting to the digital age, but when their algorithms and pricing models exclude those with intermittent connectivity or lower digital fluency, they risk deepening the very inequities that healthcare should reduce. And beyond those with poor signal, there are vast populations with no insurance coverage at all. For them, the fallback is stark: out of pocket payments for whatever care they can afford, or simply enduring pain and inadequate diagnosis when they cannot. A reality that no algorithm can yet address. Finally, governments, arguably the most influential players. They oversee the transition from manual paper files, dusty registers, handwritten notes, physical folders, to electronic health records stored in the cloud. The ambition is commendable: seamless data sharing, better disease surveillance, fewer lost records. But consider Khalid, the adolescent son of Al Rashid's family. His vaccination history and recent allergy tests are stored in the hospital's computer. But those of his parents remain scattered across multiple paper files in different clinics. When Khalid needed a routine checkup last month, the doctor accessed his history instantly. When his dad, Omar, had to renew his driving medical certificate, he had to carry a folder of printed reports from three different clinics because his digital record simply does not exist yet. This fragmented transition is typical. Even in wealthy nations, interoperability remains a headache. One hospital's computer cannot talk to another's. And when governments fail to mandate interoperability, manufacturers have little incentive to make their systems talk to each other, leaving patients to navigate the silos alone. We will explore these regulatory and infrastructure challenges in depth in upcoming episodes. But let us not forget that it is not all anxiety and crashes. International health organizations and experts have long documented the deficiencies of manual systems: lost files, delayed data, avoidable drug interactions, fragmented care. The promise is real, but it is conditional. It depends on whether we design for everyone, not just the connected. So, back to our opening dilemma. If technology cannot perfect a game, what hope for healthcare? The honest answer is this: there is no perfect answer, only choices. The struggles of Al Rashid's family are not unique to their semi urban town. They are echoed even in the most advanced healthcare settings, where patients also wrestle with confusing apps, fragmented records, and impersonal algorithms. Digitalization is not the final destination, it's the beginning of a new kind of care. And this episode, it is a beginning of a new series. Stay with us. And to self correct, VAR in football stands for the video assistant referee.
And now it's time for the Dispatch, a monthly opinion from a clinical expert who responds to our query related to last month's topic, the rise and rise of elderly. So we wrote to the practicing physician, Bilal Zafar, to tell us something on prevention and rehabilitation of serious falls among the elderly, one of the most consequential events of old age worldwide. Let's play the recording sent by Bilal.
Thank you, Erin. Thank you, Shanur. Hello, listeners. I'm Dr. Bilal Zafar, and I'm often involved with elderly care. So, a very interesting email you sent me, and it's something that we often have to deal with. Some of the things we can do at home just to make sure we're a bit more safer is all those loose rugs, those carpets that are present in the hallway, all those pieces of furniture that are lying all around where you can easily stub your foot, you can easily slip over. All of that needs to be moved away. Got to make sure the floors are nice and unpolished where your feet can grip easily. In case you have polished floors or in case the floors are slippery, make sure your shoes are nice and grippy. Try to avoid wearing socks, or if you do wear those socks, make sure they're the ones with those little grip pads underneath them. Make sure all of those areas you normally frequent at night are well illuminated and well lit. And have rails installed on the hallways and in the bathroom where you could use them to grip and help yourself walk around. In case you do fall, scream, yell, make sure someone around hears you. Try to engage with your community just so you guys can be in touch with each other if someone has such a scenario going on. These days we have watches and we have pendants that can automatically alert our next of kin or our emergency contacts regarding the falls. If you do have a fall, just remember the road to recovery is quite long and you're going to be involved with a lot of healthcare professionals, allied healthcare professionals, including physiotherapists and family members who are going to support you along the way. The goal of the treatment over here, the goal of everything we're doing after that fall is going to be to try and get you back to the same level of autonomy you had before. You got to make sure in public areas you are heard. It can be quite crowded. You got to make sure someone can hear you, and if you get lost, don't hesitate to ask for directions. Working with older patients is a complete experience, and it's quite necessary for good clinical practice, in my opinion. You see different chronic diseases presenting in different stages, and that gives you more perspective. You also get to offer more holistic care because these patients don't only have medical needs, but they also have social needs. If you would like to discuss scenarios that are specific to you, get in touch with your doctors. And that's it for me. Back to you.
And a big thank you to Dr. Bilal Zafar for the dispatch. That's it for now, folks. I'm Erin Rodgers. See you next week.
Technical support for this show is provided by Wahab Shahid. Podcast logo, theme music, creative and production advice is given by Imran Badr. Erin Rodgers is our editorial associate. Population Health Weekly is led by its listeners, and they are invited to participate in any competent way they can. If interested, email us at info@ideas.org.s, info@ideas.org.es.
Subscribe to our YouTube channel, Population Health Weekly, where you can also post your thoughts, comments, and imaginations. You can also subscribe to our monthly newsletter on our website, ideas.org.es. It's free. You can also donate to us through ideas.org.es and the hosting platform rss.com. All contributions will be dedicated to improving the quality of this show. The transcript of the show will be available as soon as it's posted via rss.com. If Population Health Weekly sounded interesting to you, then spread the word.
Special thanks to Junta de Andalucía and Gobierno de España for their support to Autónomos that made this production possible. Next week, refasten the seatbelts. Join us.